Welcome to the presentation on dyslipidemia. This presentation will begin with an overview of dyslipidemia as well as the most recent cholesterol guidelines from the American College of Cardiology and the American Heart Association. Then we will go on to cover the different classes of medications used to treat dyslipidemia. Cholesterol is a waxy fat that is carried through the bloodstream by lipoproteins. There are three main types of cholesterol. LDL or low-density lipoprotein is your bad cholesterol, HDL or high-density lipoprotein is your good cholesterol, and the third one is triglycerides, which are the fat in your blood. The good cholesterol or HDL is stable and carries the bad cholesterol or LDL away from the arteries. The LDL is the cholesterol that sticks to the inside of the artery walls and contributes to plaque buildup within the blood vessels. The term dyslipidemia is used overall to describe an abnormal elevation of cholesterol in the blood. With the publication of the new guidelines in 2013 came a new way of calculating cardiovascular risk, the ASCVD risk calculator, which stands for atherosclerotic cardiovascular disease. This calculator replaces the Framingham risk calculator, which was previously used in the old guidelines to calculate cardiac risk. It is recommended to use this calculator to estimate the 10-year ASCVD risk in both African American and non-Hispanic white patients. This is the population the calculator was designed to be used in. However, keep in mind this excludes Hispanic and Asian American patients. The new calculator estimates the risk of non-fatal MI, death from coronary heart disease, and now includes fatal and non-fatal stroke, whereas the Framingham risk calculator did not previously include fatal and non-fatal stroke. The calculator uses age, sex, total cholesterol, HDL cholesterol, systolic blood pressure, whether or not the patient is being treated for high blood pressure or has diabetes, as well as smoking status to calculate a patient's risk. Also, there is some concern that the new risk calculator may be overestimating the risk by as much as 75 to 150%, so that is something to keep in mind. But it is important also to remember that this is simply a tool to estimate risk and should not take the place of clinical judgment. Here's an opportunity to try out the risk calculator. Use the link provided to access the risk calculator tool and calculate the ASCVD risk for the patient listed on the slide. What do you get as her 10-year ASCVD risk? You should get right around 15.3%. Before we discuss medications, it is important to touch on the non-pharmacologic treatment options. All patients can benefit from the addition of therapeutic lifestyle changes. They may need to make some dietary changes, such as limiting the intake of foods high in cholesterol. Increasing aerobic activity helps to manage cholesterol levels as well, especially by increasing the good type of cholesterol or HDL. Weight reduction may also help manage cholesterol levels, and tobacco cessation will help to lower the cardiovascular risk for patients that smoke. The first and most important class of cholesterol-lowering medications are statins. As you can see, all of these medications end in the phrase statin. The most common statins used are simvastatin, rosuvastatin, atorvastatin, and pravastatin, but there are other statins available. Statins are also called HMG-CoA reductase inhibitors because of their mechanism of action. HMG-CoA reductase is an enzyme that plays a role in cholesterol synthesis, so by inhibiting this enzyme, statins work to decrease the production of cholesterol within the body. The most common adverse effects of statins are nausea and elevated liver enzymes. More severe adverse effects include myalgias and rhabdomyolysis. Myalgia is defined as muscle pain and most often occurs in the larger muscles of the body, like the large muscles of the legs. Rhabdomyolysis is a destruction of skeletal muscle tissue and can result in kidney failure. This is a rare side effect, but it can be life-threatening and is often associated with the use of statins like Zocor or simvastatin. Because of the metabolic pathway of statins, they are contraindicated in patients with active liver disease. Statins are also contraindicated in pregnancy and are pregnancy category X. As cholesterol is necessary for fetal development, the use of statins during pregnancy can be detrimental. There are 4 major statin benefit groups identified for whom ASCVD risk reduction clearly outweighs the potential risk. Group 1 consists of individuals with clinical ASCVD. Group 2 consists of individuals with an LDL level greater than or equal to 190 milligrams per deciliter. Group 3 consists of individuals with diabetes aged 40 to 75 years, also with an LDL between 70 and 189 milligrams per deciliter, and these patients do not have clinical ASCVD. And then finally, Group 4 consists of individuals between 40 and 75 years old without clinical ASCVD or diabetes, but with an LDL level between 70 and 89 and an estimated 10-year risk of ASCVD greater than or equal to 7.5%. The estimated absolute 10-year risk of ASCVD is defined as non-fatal MI, death from coronary heart disease, and both non-fatal and fatal stroke, which again is calculated using the ASCVD risk calculator from the 2013 guidelines. Individuals in the first group may be treated with a high-intensity statin if less than or equal to 75 years old, or a moderate-intensity statin if greater than 75 years old. Group 2 individuals would be treated with a high-intensity statin. Group 3 individuals may be treated with a moderate intensity, or if their estimated 10-year ASCVD risk is greater than 7.5%, they would be treated with a high-intensity statin. And finally, Group 4 individuals would be treated with a moderate to high-intensity statin. On the next slide is a table summarizing the groups and the statin intensity therapy. There is no evidence to target LDL levels, even despite decades of treating individuals to specific LDL goals using the previous guidelines. The new guidelines favor instead a percentage change in LDL from the baseline LDL measurement. The rationale for this change was based on the fact that the expert panel was unable to find evidence from randomized controlled trials to support titrating cholesterol-lowering drug therapy to achieve a target LDL level because there are not randomly controlled trials that were treated individuals to a specific LDL target. Instead, the randomized controlled trials have demonstrated a cardiovascular risk reduction using specific statin doses or intensities of statins instead of the targeted LDL goals. Therefore, the recommendations are no longer made for or against specific LDL or non-HDL goals for the primary or secondary prevention of ASCVD. Instead, the focus is on the intensity of the statin therapy, and on the next slide you will see a table of different statin intensities. The first column on the left lists the statins considered high-intensity statins. As you can see, atorvastatin 40 and 80 milligrams and rosuvastatin 20 and 40 milligrams are listed in this column. To be considered a high-intensity statin, the statin on average lowers the LDL by approximately greater than or equal to 50%, whereas moderate-intensity statins lower the LDL by approximately 30 to 50%, and the low-intensity statins lower LDL by less than 30%. Specific statins and doses are noted in bold that were evaluated in randomized controlled trials. Statins and doses that are approved by the US FDA but were not tested in randomized controlled trials are listed in italics. Remember, statin intensity is determined based on which of the statin benefit groups the patient falls into. With the new guidelines that looked at all the previous evidence and studies and literature, non-statin therapies have now taken a back seat. There were few randomized controlled trials performed with non-statin drugs and no evidence supporting the routine use of non-statin drugs combined with statin therapy to further reduce ASCVD risk. However, the addition of non-statin cholesterol-lowering therapy should only be considered in a few patient groups. Those that are high-risk patients who have a less than anticipated response to statins, patients who are unable to tolerate the recommended intensity of a statin, or patients who are completely statin intolerant. Let's try another case. Paul is a 56-year-old man with hypertension, diabetes, and renal disease. He comes in for a routine checkup and has an ASCVD risk score of 9.5% with an LDL of 160 milligrams per deciliter. Would Paul benefit from the addition of a statin? Yes, Paul would benefit from a statin. His risk is greater than 7.5%, and he fits into group number 3. His age is between 40 and 75, he has diabetes, and his LDL is between 70 and 189 milligrams per deciliter. What possible side effect from statins would you educate Paul before he leaves? A. Muscle cramps. B. Increased urination. C, mood changes, or D, cough? The answer is A, muscle cramps. Paul should be educated on the risks of myalgias or muscle cramps in major muscle groups. Rhabdomyolysis is the destruction of skeletal muscle tissue that can result in kidney failure. Remember, this is a rare but life-threatening condition and associated with the use of statins like simvastatin. Now on to a few other classes of cholesterol-lowering agents. Zetia, or ezetimibe, is a cholesterol absorption inhibitor and works by inhibiting absorption of cholesterol in the small intestine. Common adverse effects include diarrhea and arthralgias, and like statins, it is contraindicated in active hepatic disease. Until recently, it was undetermined whether or not Zetia had any clinical benefit. However, the Improve It trial, published in 2015, showed that the addition of Zetia to a moderate intensity statin reduced cardiovascular mortality, major cardiovascular event, and non-fatal stroke when compared to statin therapy alone when used in patients with recent acute coronary syndrome. The next class of cholesterol-lowering medications are fibrates. Gemfibrozil is an example of a fibrate. Fibrates work by decreasing the synthesis of triglycerides in the liver and increasing the removal of triglycerides from the body. Combination of fibrates and statins were highly used in the past to target both the LDL and bad cholesterol along with triglycerides. However, concurrent use of fibrates and statins have shown to increase the risk of myalgias. So now, fibrates are typically reserved only for patients with very high triglyceride levels, like incredibly high, 400 to 500, because these patients are at risk of developing pancreatitis. The last drug class we will cover are PCSK9 inhibitors, which is a brand new class of medications. These include brand names Praluent and Repatha. They work by blocking PCSK9, which allows for the production of more LDL receptors to remove LDL particles from the blood, therefore decreasing the LDL levels in the blood. It is important to note that PCSK9 inhibitors are only indicated for familial hypercholesterolemia, which is a genetic disorder that causes cholesterol to be incredibly high even with a good diet or lifestyle changes, or for individuals with clinical atherosclerotic disease requiring additional lowering of LDL. So it is highly unlikely that you will see these medications in practice. In terms of LDL lowering, however, they are incredibly effective, with lowering LDL around 50% on top of maximum statin use. There have been no studies yet on cardiovascular outcomes. We know it reduces LDL, but we don't know for sure yet if it prevents cardiovascular events or deaths. These studies are long-term and require more time. So since these agents just came out, we should have some results for these studies probably in the next year or two. These drugs are also injectable and are administered monthly or bi-monthly and are incredibly expensive, so they should be used cautiously and wisely. To wrap up this presentation, here are some additional references that may be beneficial for your understanding of dyslipidemia. The first is a link to the ASCVD risk calculator to help evaluate patients and determine the course of therapy. The second link on the slide is the current dyslipidemia guidelines put out by the American College of Cardiology and the American Heart Association.